Right, we're all comfortable? So let me start with a question perhaps to Professor Birch. Steve, you know, for decades now, health expenditure has been outstripping income growth for decades. So is that a problem? Is it something we need to be worried about?
Well, I think it's a problem because if it carries on, there's going to be serious problems. There's obviously a limit, but it's not a problem that's unmanageable. What we have to consider is what are we getting for that, and to what extent does that coincide with the needs for healthcare in the population. What's sort of surprising to health economists is it tends to go up around the same time as the needs in the population are actually going down. Health is getting better over time in most countries, certainly the high-income countries, yet we seem to be spending more on health, so we're not actually tracking our health expenditures with the needs of the population. And I think that goes back to the way that healthcare is not a normal commodity. You can't rely on the market of demand and supply because we don't have a clear demand for healthcare from the population. It's influenced by the supply side.
And so essentially that's what economists mean when they say, is healthcare a luxury? It's essentially that as income increases, expenditure tends to increase, but more than income is increasing, which is why we see that drift in expenditure over GDP.
Yeah, and more than needs as well.
And more than needs as well, yeah. Professor Zweifel, Peter, you, I guess it was 18 years ago, wrote quite a famous paper that started really a sub-discipline within health economics. It became concerned with what at the time was quite a controversial suggestion that ageing itself is a red herring. Can you tell us a little bit about what was your hypothesis, what were you seeking to test?
Yes. Think of what we would like to see as a health profile. Isn't it true that presumably most of us would be 100% healthy and then drop dead? In the medical profession, this is known as the perfect rectangularization. Beautiful word. Now, unfortunately, our trajectory is not going to be fully rectangular. But when will be the deviation maximum? Shortly before death, right? That's when we begin to drop. And we want to go back to that angle using healthcare expenditure. So no wonder age per se is not so important, quite likely. It's that closeness to death. And at that time, it was end of the 90s, we had the privilege of having access to insurance data where we knew the time of death of the person, we knew the calendar age, and we had a so-called panel where historical time also changed. And among those three time concepts, in the end, in the statistical analysis, it was historical time that survived, as one says, was important because there was always new medical technology coming in, and it was closeness to death, not age. And at that time, that was really a challenge to perceived wisdom, yes.
We might come back to that in a moment, but Professor Gannon, Brenda, you've done quite a lot of work in ageing and dementia, but that you were also talking about this recently, that it once again, maybe not ageing, but actually longevity that might matter.
Yeah, I mean, this has actually been a really timely and an interesting week, because just this week we've had two reports, one on the World Health Organization, the life expectancy, showing how life expectancy of those born in 2010 compared to those born now, and 3 years additional in terms of Australia. So that's what's driving expenditure. It's not the poor old people as such who are getting a bad press in terms of aging, and once you reach a certain age, that's an issue. And in addition as well, in terms of another report this week, dementia costs in Australia, a report came out, quite closely followed methodology of that in the UK recently, which, you know, it shows the cost to be really enormous, like they say up to 1 trillion by 2050. And yet if you read through the report and see the ins and outs, it may not have considered comorbidities, it may not actually be as expensive as we think. And how can we actually extend out to 2050 if we don't actually, it's quite a long way to know the numbers of people with dementia. So there is expenditure coming. Of course, there's a rising expenditure, but it's very hard to predict exactly in terms of aging what it actually, we could look through the next few years, but after that.
But one of the other, one of the things that I think in that report as well is they're predicating some of the containment of costs due to ageing and dementia in particular to technological changes that will save money. What do you make of those?
Yeah, so that's been really interesting too, because I was looking through the report and go back to the National Dementia Strategy here, and they say if there's a 5% new technological advancement will reduce costs by 5% in the forthcoming years. But there's no actual evidence of what is that advancement, what is that treatment that's coming through. And it's actually an assumption. So these assumptions are quite vast, and we are economists and we make assumptions, but we have to be quite clear and transparent. So the headline figures are a lot more dramatic, I think, than actually if you read through the report itself. So it really is interesting, yeah.
So in relation to medical technology and technological change, we now believe as economists that, in fact, a majority of the growth of health expenditures is due to technological change. In fact, one of the things that we know as well is that there aren't very many technologies in the health sector that are actually funded and make their way onto the market, especially with public subsidies, that actually save money. There's about 6 to 18% or something like that of the published literature shows reduced cost and additional outcomes. So we're actually seeing a growth in health expenditure possibly due to these health improving technological changes. Are we managing that process very well in countries like, for example, the States, where there's perhaps not as much attention given to managing the diffusion of those? In Australia and other countries, there's much more attention to which of those things, not so much get onto the market, but which things we subsidise and which we don't. Are we doing a good job of that at the moment?
You want me to?
Yeah, sure, Steve.
Yeah, I think our whole principle in the economics field is that if something's better than something else, then we replace it. We've not been very good at replacing in healthcare systems. We've been very good at adding on. And so while something has the potential to be brought in and replace something because it's better than it, we don't save those resources from the other things. And I think it's continually expanding the costs as a result of that. So certainly in terms of health workforce, when things like the nurse practitioner was introduced in the UK, and as many of you will know, the nurse practitioner is an advanced nurse who is able to do many of the things that a doctor can do. That was seen as going to be an important way of saving money whilst maintaining high quality care. But of course the nurse practitioners did not replace physicians, they added on to them. So here was good evidence to show we could save money if we managed the implementation of a technology, in this case a human resource, but we didn't implement it that way. So we had the same number of physicians, even more, as well as the nurse practitioners. And so I think that's a good example of how we often fail to take advantage of the evidence we have. It comes down to important implementation issues.
Would you say in relation to, in health economics, I guess many of us are interested in the field because of the possibility of so many sources of market failure, but we know governments fail as well. In respect of workforce supply, how heavy a hand do you think governments need to take in markets like the Australian market?
Well, there's the old rule in health economics of a built bed is a filled bed, and it's the same with a physician or a nurse practitioner or any supplier. If you create the supply in healthcare, that supply is going to be used. So even as needs change and we make advances in epidemiology and we improve the health of the population, you often don't see that being reflected in reductions in supply for that sort of area. And one good example, which is going back to certainly my youth, which is probably a lot longer than many of your youths, is dentistry. I did quite a bit of work in dental care, and in the 1970s in the UK, where I was at the time, there were major advances in the oral health of the population, in particular children. And these came from sort of public health issues like improvements in oral hygiene, like fluoridation of toothpaste, and in some cases of the water supply. So caries just plummeted in the children's population. But we didn't see any reductions in dentists. which you would expect, because this was a major component of a dentist's workload. And of course, you know, dentists were looking to fulfill their workloads, and that tended to coincide with the widespread use of orthodontics in children's population. I'm not talking about the serious malocclusion of jaws and teeth. I'm talking about, I don't know about in Australia, but certainly in North America, it's almost a rite of passage. You know, all children are referred to orthodontists. And so what's happened is, to fill up that gap that resulted from an improvement in population health, a new thing was introduced, not by governments. I mean, it wasn't like the UK government at the time was saying, well, we suddenly discovered that, you know, our armed forces can't function properly because some of them have got bent teeth. And it wasn't because we had mothers marching on Parliament saying mothers against bent teeth. This was coming from within the profession. It was not coming from a planned government policy that we needed this. It was a way of filling up the capacity of existing supply. We didn't reduce the throughput of dental schools, we actually increased them at the same time.
I mean, one of the interesting things to economists, I guess, is that we have what I saw in a book recently described as not a health system, but an ecosystem, where in fact you've got individual players trying to survive on different terms. And actually, you know, unlike, if you think about disruptive technologies that have occurred, say, in transport with Uber, you know, it's actually obviously reduced transport costs a lot for consumers. Consumers care about that reduction in price. It's actually still cheaper in Australia to get a GP to your door than it is to get a pizza. It's zero price, bulk billed in your own home. It's hard to see disruptive technologies of that kind actually affecting that market, which is partly about insurance and the lack of any copayment. Peter or Brenda, would you like to comment on the lack of copayments and whether or not any copayment is a bad thing?
It's really puzzling for people from outside the healthcare sector, what Professor Connolly pointed out, that outside the healthcare sector, technological change is almost always cost reducing. Whereas in the healthcare sector, it's almost always been cost increasing. Why this? You see, you need to distinguish between so-called process innovation and product innovation. What's the difference? Process innovation means exactly the same, but please at a lower cost. It's not popular with employees. But international competition, think of cars, like South Korean cars now, they force producers to also adopt process innovation. Product innovation is different. It says, let a service or a product be bestowed with new qualities, better characteristics, better attributes. That means willingness to pay by consumers will be enhanced. But that creates, of course, the leeway for higher cost, higher price of sale. Now, I would argue that the balance between process and product innovation is disturbed in the healthcare sector, notably by health insurance. If you have, say, 10% copay, and the physician offers you something that would have process innovation, but no new attributes that you're interested in, would you take it for 10% cost reduction to your pocket? Forget it. You want to have the newer product, right, with enhanced. Your willingness to pay is enhanced through that. And health insurers on the long term, they have to admit these new things because they know full well that their clients want to have access. And maybe we'll talk later about measurement of willingness to pay of people in the healthcare sector. I mean, patients and insured people. And they point invariably to quite substantial willingness to pay for new procedures, new therapies.
But at the same time, it doesn't take much to make people care something about their expenditures, right? So we know that, say, from the Rand health insurance experiment and other empirical evidence, and this is a gross generalisation, but at about 20% copayment, you get moral hazard or overconsumption, essentially, fizzing out. So it's not always necessary to charge large copayments to get people to think about their consumption. Would you agree with that?
No, I wouldn't argue for a very high copayment. And that also means in the end, it's you and me who pay the whole show in this healthcare sector, please. So if our willingness to pay is there and it's increasing as part of our income, maybe increasing even faster than our incomes, because we would like to have that rectangular profile, don't forget. What's wrong with that? Maybe it's our governments who would like to push that ballooning healthcare bill out of their budget. At least in the case of Switzerland, I have experienced that. I was counselor to the federal government on the new law on health insurance, and all they wanted is reduce the subsidy that they have to pay by constitutional decree for the lowering of health insurance premium of poor people. That was what really drove the debate, not the grassroots view of people. They know full well that they have access to new therapies, that hospitals don't look, at least in Switzerland, they looked 20 years ago. Now you have, even in the public ward, just 2 beds, maybe 1 if you're a difficult case, not 4 anymore. People know that's costly, but governments know that with health for all, the slogan of WHO, you don't win elections anymore nowadays. So push it out of your budget, please.
Could I ask? Yeah, sorry.
But it also depends on the perspective that's taken. I mean, you say cost savings, and it depends what perspective. If it's just off the healthcare provider, you haven't looked at the other side of the economy. And the opportunity cost, the word we love in economics, is looking at, as you said, what is being displaced. And so new technologies say cost savings. What do we mean by that? Is it short run, long run? And is it what perspective? And in the long run, we possibly don't even know yet. And in perspective-wise, I think there's always a danger of just looking at it from one side of the equation only. So I think that's, that's something that has to be borne in mind as well.
And Brenda, you've worked quite a bit on efficiency measurement as well, and I wonder if you'd be interested in talking a little bit about that in respect of hospitals and so on, and perhaps whether or not you may have looked at, say, scope of practice type issues and whether they affect efficiency and ability actually to take advantage of innovations that maybe don't seem disruptive. Mind you, not all disruptive innovations are instant, but could you talk a little bit about efficiency measurement?
Yeah, I think it'd be quite interesting to look at efficiency of the sector and see the amount of resources that maybe if you compare A and B doing the same thing, maybe one with the new technology using the extra resources due to that's required for repeat treatments, etc. And then actually at the end of the day, the same outcomes may come out in terms of help to the patient. So that in terms of efficiency, how we can analyse that is inputs in, outputs out. And the inputs in would be capital labour, the skill mix based in the healthcare sector. And then the outputs would be the number of patients treated, but more importantly, what we've had looked at before in hospital efficiency is quality. And that brings us on to measurement then in health economics. How is that done? And quality is quite hard to measure. Often it's just briefly, widespread use of mortality measure. And then now we have more KPIs in hospitals, etc. We can look at patient satisfaction and bring that into it too. So I think there's actually quite a lot of scope for efficiency gains that we may not know about yet, and that could possibly lead to reduction of costs. We're always trying to trade off equity and efficiency and health inequalities, etc. So I suppose it's how far do you actually go in terms of efficiency? You don't want it to benefit one side of the population than the other. So.
And indeed one of the underpinning factors for the Medicare system itself, one of the guiding principles are some statements which aren't very well articulated in terms of measurement, but about equality. And while we're talking about equality and efficiency, if we move on to inequality, and in particular Indigenous health, of course we have a very wide Indigenous health gap in Australia and Canada and elsewhere. I wonder if, Steve, have you got any ruminations on that Indigenous health gap in Canada as well as Australia?
Well, certainly in Canada, I've done some work, quite a bit of work with First Nations populations, which I think have got similar sort of challenges in the health of the Aboriginal population here in Australia, and it's not good enough for governments to wear the heart on the sleeve and throw money at healthcare alone, because you're missing the point. The social determinants of health of the Indigenous populations of Canada are so poor, so in absolutely terrible circumstances. It doesn't matter how much healthcare you throw at them. You've got the upstream and downstream problem. If the bridge is broken, you're going to have to pull the guy out of the river, but don't put more people in pulling them out of the river. Fix the bridge. And in Canada, to retain their band status, which qualifies the Indigenous population for many social benefits, they're required to live on reserves. And the reserves are built for them by the federal government. And those reserves are what you might see in the townships of South Africa, actually. Appalling conditions. They're most of them are in the very north, very cold climates. Most of them don't have running water or sanitation. And we expect them to produce healthy populations. I mean, it makes no sense. And what was interesting to me was many years ago, as South Africa were making its democratic changes, Bishop Desmond Tutu was doing a tour of North America. And he was in North America for about 6 weeks, and his last port of call was Sioux Lookout Zone, which is in Ontario, about 400 or 500 miles north of Toronto. And we had a premier of the time, who I'm not sure I could align him with any of your premiers here, but let's say he was on the right, and he was called Mike Harris, and he was always one for photo opportunities. So he was there in the Sioux Lookout Zone. That's the first time he's ever visited it. And Desmond Tutu was there, and Desmond took his hand and he shook his hand and said, "Premier Harris, I want to thank you for bringing me here." He says, "because I've been away from home for 6 weeks now, and this reminds me of home." And it went straight over his head. And of course, if you throw money at the population and think that's going to solve the problems, what happens if you go up there is you find out that what they're using are things they can buy in the private market. You can't buy access to clean water. That's a municipal public decision. When we got access to clean water in the white population in Canada, it was a municipal decision. So giving them money means the marketeers come in to sell products to them, and the products tend to be satellite TV that has, pornographic channels. The one product that is fixed price in the whole of Ontario, what do you think it is? Booze. Everything else is 4 times more expensive in the north than in the south, but booze is price fixed. So the amount of booze, the amount of sugar you have to give up for a pint of beer is much more there than it is in southern Ontario. The whole opportunity cost is out of whack. So obviously we need to make sure that they have access to good quality healthcare, but that's not going to change their health unless we also change the social determinants of health for those people.
It goes even further than that. When I was in South Africa back in 1997, I was challenged. I taught some health economics there by a participant who said, "I have to advise the ANC government, the new government, about the list of benefits that should be covered." I said, "Who is to benefit from this?" "Oh, of course, our black majority." Then I talked to a couple of people. "Do you really like white man's medicine?" "Oh, no. No. We go to the voodoo, usually, first. And only in some special cases would we revert to white man medicine." See what happens? Black people there are forced to contribute to a scheme they're not even much interested in. So I'm very hard-necked economist. Willingness to pay, try to measure it, try to measure the preferences of those who end up paying for the show, please. And I'm convinced most of these voters of ANC would not have been willing to pay very much for, say, an ample list of benefit of the white man.
So, I mean, moving from that insurance example into the Australian insurance situation, we have a public system, it's universal and you can't opt out of it. We have a very large proportion now of the population also buying private health insurance, and some of the work we've done suggests that if not for the tax penalty, the entire market would probably collapse, as it looked like it was going to do in the late 90s. So if there was something you could do to change healthcare financing in Australia, so one thing, what would you recommend that Australia would do?
Yeah. Measuring willingness to pay is, of course, a big challenge. Just an example. You'd be willing to pay out of pocket 100 Aussie dollars at the pharmacy, right? And the copay is 20%. What will that drug maximum cost at the pharmacy? 500, because 20% of 500 is 100, and you'll still buy it. So our willingness to pay as observed is, of course, inflated big time by health insurance coverage, or the government paying. In the UK, it's just the government that pays, that plays the role of the health insurer. Simple as that. So we cannot trust market observations. Second best, experiments. They're not perfect, but we have done a few of these experiments regarding, for example, new technology, new therapies. You can always argue it's hypothetical, right? But it's probably the second best, and it's better than just not listening to the preferences of those who end up paying. That's all I can say.
I have a slightly different view. I wouldn't disagree with you on doing those measurements, but I think governments have an ethical perspective to take as well, to condition those, because, I mean, at times you'll go through periods, and I think, Canada and probably Australia went through a period, for example, in the early years of HIV and AIDS, where if you'd gone to the public to ask about how much should we be spending on HIV treatment, there might have been a time when they said nothing. That's something that has come from behaviours we don't like and those sort of things. And so I think governments have always got an ethical perspective to listen to the public and then say, well, just a minute, how does that fit in with our ethical view of the world? And certainly if you go to sort of referenda for things like capital punishment, if you rely on referenda, I think in most countries you probably find that the majority of the public would vote for capital punishment, just like the majority of the public voted for Brexit. And that's not necessarily in the end going to benefit the country. I'm not suggesting the government shouldn't take that view. Shall we say, I have to be agnostic on that. But in terms of capital punishment, I think there's always a case for the government to consider whether it's got an ethical perspective that doesn't want to adopt what might be a populist view. And I think what we've seen in Brexit, but also in North America now, is the populist view and the view of the public can sometimes be manipulated in a way that might not be in the best interests of not only our current population, but our future population who don't currently have a vote, and our youth as well who don't have a vote. So I'm all in favour of getting the information, but then how you use that has to be done in a sort of an ethical lens.
Yeah, I agree to some extent, because willingness to pay is not just everything, but it's actually a really interesting part of the process. I was just involved in a study, still am, with biomechanical engineering, where they've developed a new device to detect foot ulcers in people with diabetes. And we did a willingness to pay study, and I actually didn't even know the price of the device. And we did the study and we got back the results, and the person working with me on it gave me the results, and I said, well, actually, what is actually the cost of this? Because we need to be careful what we say here. And it turned out that we were close to the actual cost in terms of developing the device, not the actual sale price, because that's going to go beyond that again when it's commercialized eventually. So that to me was really interesting. I thought, okay, so the public actually will pay this amount for this device. But it was a cheap device, as in £100 or something for a device. If you go to something a lot more expensive, more higher end treatment, then the willingness to pay may be slightly less. But I think it's a good part of the process. It's something you were talking about earlier, about how can governments intervene. If that's brought into national planning, and I've seen this in where I'm from, in Ireland, where we've had national strategic documents, and we've been asked as economists to do willingness to pay studies, or in fact just the cost of illness itself in terms of falls prevention. And once that's written down, it feels like it's going somewhere, and it actually is. 10 years later, they still have a prevention programme based on the findings from that strategic document. So willingness to pay can come into that.
So I wonder, economists now are much more involved in these processes when a product is already on the market. The question is the public going to subsidise it in the UK, in Australia, Canada and elsewhere? And so economists are involved at that end of the process, but what do you have to say about the involvement of economists in other parts of the policy-making process? Do you think greater involvement's required?
Yeah, I think there's involvement everywhere, actually, unfortunately for us, because it makes our day very busy. But there's involvement from the very beginning, and if we're looking at that end where you're talking about the evaluation at the end of the day, we still need to know from day one what's actually going to happen here in terms of how we want to model the cost effectiveness. But going back a few steps, if we're not at that stage of the research process, there's still room for economists in terms of looking at willingness to pay, the public preferences, the resource allocation mechanisms. So there's a sort of a stage 1 to 4 process for economic research along with the medical research as well.
I'd like to come back to your previous question.
Yeah, sure.
And that was about what you do about financing.
Yeah.
Okay. So what I would do is I would introduce legislation to say that the public funds that are allocated to healthcare should be directly related to measures of need in the population. Okay, and so that would have great counter-cyclical effects, because the needs go up when the economy goes down, so that would help with the economy. But it would also ensure that we weren't increasing healthcare expenditures unnecessarily, arising out of lots of things, not only the interests of the providers, but I mean, if you just think of some of the examples we have of really bad government management of healthcare initiatives. Australia was the first to come across the example with the cataracts, where cataracts went from a 3-day length of stay in hospital to a 20-minute procedure, but they paid the physician the same fee. Well, how crazy. That's just pushed up your expenditures, God knows how much. Okay, so what you need to do is adjust your fee there to reflect the effort and the inputs that are required to produce the same output. We didn't do that. A very recent example in the UK, David Cameron as Prime Minister went to an election trying to win votes by saying he would have 24/7 primary care. So he would pay physicians to family physicians to open the practices in the evenings and at weekends. He'd pay them extra. And these were large amounts, and so they were very pleased with this, so they paid them. And they've just come out with a report in the last month to say what happened was they took this money and then they closed the practices during the day, for which they didn't lose any money, because the contracts did not specify what their hours during the day was. Now, you might think that's a bad physician. I don't. I think it's a bad contract. And I think the people who designed that contract perhaps should be looking for another job, because they're not suitable in the job they've got. And we've got lots and lots of examples of that. Don't blame the people for responding to the incentives rationally. Blame the people who are creating these crazy incentives. And we've got so many examples of that where we could save money whilst not affecting anybody's healthcare at all.
Yeah, we found a similar thing in Australia a few years back. The government increased the rebate for GP services from 85% to 100% of the schedule fee. And the work we did on the volumes of services suggested that busy GPs took the income dividend and took more time off, so services actually fell. So it's one of the rare cases of the backwards bending supply curve, as we call it in labour text, that you don't expect to see in practice. Usually we saw it. So, but I think one of the other things you were talking about, Steve, on another occasion was that, and I wonder what the fit is between the way practitioners are remunerated in the UK compared to the fee-for-service way they're remunerated here. However you think about that system in terms of consumer benefits of fee-for-service, say, over capitation, do you think it's the capitated model that's in place in the UK that actually means that there's much more cooperation around things like professional boundaries, so that you don't have these rigidities in scope of practice that we see in, say, Canada and Australia, for example?
I think there still are plenty of rigidities in there. I don't think we should paint a false picture of the UK. So, I mean, they've tried to introduce physician assistants, and they've faced this big resistance to that. But in terms of capitation, solution. I think it gives you the opportunity, if it's implemented properly, to align your payments with your needs. The fee-for-service system aligns your payments with what you do, not the needs of the patient you're doing it to. So if well, not me, I'm not a clinician, but I mean, if my clinician friend decides to do a cataract procedure on someone who's got real bad cataracts, that attracts the same fee as someone who's got it marginally. And what we're seeing in Canada is the point of intervention for cataracts is getting lower and lower. There's too many ophthalmologists, too many in inverted commas, because now cataracts are done on a production line, 20-minute procedure, so you can get lots done during the day. We haven't reduced the number of ophthalmologists, so they're trying to find things to fill out the day with, and so they're reducing the point of intervention. And I was actually at a conference about 3 years ago where there was an ophthalmologist stood up and said that he believed that because people are living longer now, everybody's going to need cataract surgery at some point in their life, so why don't we do it prophylactically at age 55? I mean, I know it sounds like I'm here doing a stand-up routine, but that is a true story.
I might add, people just don't have enough eyes these days. This might be a good opportunity now to open the discussion to some questions from the audience. Could I ask you if you'd like to ask a question, to raise your hand and give your name and affiliation, if you don't mind, before you ask. There are some roving microphones over here. Any questions from the floor on any topic we've covered or anything else that we haven't? The men down the front here, please.
Thank you. Jamie Allison, veterinary surgeon. We've talked a lot about health expenditure, but I believe the current industry we have in Australia is a sickness industry, not a health industry. I always believe what gets recorded and monitored can improve, and what gets rewarded gets done. Why do we record sickness statistics instead of wellness ones? And why can't we why can't we reward the health industry for keeping people healthy instead of treating disease?
There's a great example of this, and it's in a book by a guy who was the physician to the court of Siam. He was a Scotsman. It was called John Smith. And at the turn of the century, the King Chulalongkorn of Thailand, and the court of Siam paid him a fee for every day each member of the royal family was well. And it's a fantastic, I use that in my teaching all the time. And so I think it's exactly on your point. So it's a very good point.
Again, from experiments, I know that the medical profession is one of the most risk-averse. So would you want to be paid for health when health depends on the behavior of that patient, maybe much more than what you can do? You're at big risk, please. No, you wouldn't go for that, not ever.
Yeah, I agree. And a related point is that quality is also very difficult to measure. And so to the extent that you reward on the basis of quality, which would be great to do, you introduce further measurement error. And if your remuneration depends on quality, the noisiness of that measure also then exposes the physician to further risk on payment. So it's very difficult. I mean, it's something that we're all interested in quality measure. It's something that's very difficult to grab, isn't it?
Yeah, like in the UK, there's a lot of focus on health and well-being, so the HWB index and measuring that. But in terms of productivity to the economy, what does that actually mean? So it's a difficult concept to measure, and it's quite new, I think, in terms of trying to measure well-being of people rather than the effect of illness to the economy. And it's just another way of measuring, I suppose, and contribution to the GDP.
But in a capitation system, for anybody who's not familiar with that, a capitation system is where the provider gets a fee, which is like a responsibility fee for looking after that patient. You can do risk adjustment, and Peter's done lots of work in risk adjustment. So what you can do is you can align the fee the provider gets with the risks of that person falling ill, within, not an individual level, within the sort of group they are. So you can adjust it for age, so an older person is more likely to take more effort to keep sick than a younger person. You know, women in childbearing years are more likely to face requirements for healthcare and so be ill, have an interruption. So you can move towards it. It's never going to be perfection. But you can also, you know, use the law of large numbers, that if you're talking about a full practice, then you can use that to try and bring these sort of factors in and offer these as incentives. So I think trying to move towards a capitation system with risk adjustment for the types of patients is a way to try and get the providers to at least start thinking more in terms of prevention.
And another point as well is a lot of the measurement is in terms of averages. I think we crossed this earlier as well. But you know, there's a lot of people outside the average, and they need to be considered too. So I think in terms of measurement and evaluation, we could possibly focus more on individual cost effectiveness. And that I think that would be really interesting to see how that would work out in terms of effectiveness then.
Yeah, and unfortunately some of the models that are being used to do things like risk adjust in relation to the insurance market, the private insurers in Australia have an age risk equalisation fund. The risk adjusters are actually only age and gender. And so a clever insurer can actually take a whole range of other covariates it can observe and use whatever risk adjustment and engineer around that, which is of course good for innovation in the market, but doesn't actually do much to address the issue at hand. Peter?
You know, the minute this boils down to some financial risk placed on physicians, at least in Switzerland, you know, it was maybe one monthly income up and down. That was the max risk they would be exposed to in the experiment. You would have to pay them 1/3 more income for sure. So it becomes very costly indeed if you want to really expose them to risk. But maybe, you know, in Australia, physicians are less risk averse, I don't know.
Not on cataracts, they weren't. Can I ask another question down the middle here, please, for the mic? Thank you.
Thanks a lot. Very interesting. I'm a pathologist, haematologist. What percentage of the population of the world are we talking about? Aren't we just talking about affluenza?
Affluenza?
Affluenza, yeah.
Affluenza. Well, certainly I think there's a lot to do with it, because we suddenly find the capacity to afford levels of supply that are not justified by the needs of the population. And I think affluenza is an excellent description of that.
I think part of the trade-off there that people have to address who are interested in developing countries is actually to try and give a return to the developers and the owners of the IP that actually gives access early to populations that can't afford that. So one possibility, for example, is for large international buying groups to buy out patent rights, supply drugs at marginal cost in poor countries, so that vaccines that otherwise would have to have a long payback period under patent, the profits are actually bought out early. They're marketed at marginal cost, which may be very close to zero, and you can get instant, fairly widespread access with all the other attendant problems you'd have to address for cold chain vaccines and things like that. But there are ways of trying to address those problems for developing countries that haven't actually taken root very well so far, but they've been known for some time.
In this context, I think government involvement is not very helpful. See, even in tiny Switzerland, we have funds that insure 1 million people. For heaven's sake, let them negotiate prices with those pharma companies. No, it's the government that decides whether you're on the list or not. and the government again decides about price. Is that negotiation? No. And mind you, those pharma companies like Roche, as big as they are, the minute they want to sell their drugs abroad, first question, and how are you dealing with your domestic customers? And if they have to say, we were not able to sell our drugs to this insurer and that insurer, then they say, why should we pay what you ask for? See? Just inject a little bit of competition, negotiate like everywhere in the market, and those insurers that are successful can lower their premium and increase their market share.
Thank you. I've got a question, a couple of rows back there, please.
Ian Lake, Department of Human Services. Does the professionalism of the healthcare industry threaten to relegate equity issues to external community-based standing rather than being a part of consideration for healthcare delivery?
Well, I think if I heard your question correctly, can you just repeat it slightly?
Does the professionalism of the healthcare industry threaten to relegate equity issues to external community-based standing rather than being a consideration for healthcare delivery?
So I think this brings me to a point that I like to make about care pathways and looking at looking across the whole spectrum of evaluation of something. So not just looking at one sector of the health care in isolation from community care and trying to look across the whole thing. So I think that would be helpful to ensure that it's done across the whole spectrum, if that's answering correctly on that one. Anybody else?
There's a question up the front here, please.
My name is Dr. Suresh, I'm a pediatrician, and some of the things that we talk about in health, it is obvious countries that spend a lot less money can have very good health indices. I don't know the data across the board, but Cuba comes to an example of what circumstances they have been in and what indices they have produced. And I would probably say Sri Lanka, before the civil war, had an unbelievable health indices compared to the expenditure that they were doing. So my question is it because we have now been a victim of the electoral cycle and entitlement mentality, we have left common sense away? Or, as one of my public health professors taught me, the healthcare systems in the country, developing and underdeveloped, is designed to keep middle classes employed, and delivery of healthcare is a byproduct.
I probably won't be able to answer that question. Well, what I would be happy to comment on is the fact that, you mentioned Cuba, for example, huge investment in public health. Amazing to go and visit and see how they prioritize things. Sadly, there's another side to that, and that is, there's a price to be paid elsewhere in society. But, we can find examples throughout history as well about the importance of public health, and also taking control of the allocation of resources for things that you can't leave to the market. So not only Cuba, there's the example, and you may be familiar with this if you're from that part of the world, India. And in India, the one state that made major improvements in health was Kerala province. And Kerala province elected a communist government in the 1950s, I think it was, that brought in this focus on public health. Now, the interesting part about India, which has got a state and provincial system just like Canada and Australia, is their allocation of financial resources, the distribution of help from the federal government, they actually based it on social development measures. So because Kerala had invested in public health and achieved major improvements, the best levels of literacy in the whole of India, lots of public health measures, they got the least, they were net contributors to the federal government. So they were punished, they were economically punished for achieving major improvements in public health. And there's a book by the British author Richard Wilkinson, who writes some wonderful stuff on equity and health. When was the biggest improvement in the health of the public in the UK during the 20th century? It was during the Second World War. It had nothing to do with the National Health Service, that didn't come until 1948, but what it was the government was taking command of resources. So the allocation of resources was distributed in a much more equitable way, and that was including the social determinants of health. So we're getting back to this whole notion of the social determinants of health are the big factor, and our clinical services, our healthcare services are actually the things that come in to help support that, if you want, or fill in for the gaps for that. But if we don't put our attention on the social determinants of health and public health, we're always going to be fighting fires. And it's about time we perhaps put our attention on not letting those fires start in the first place. I don't know if that does anything to address what was a very intelligent question. It probably wasn't a very intelligent answer.
That's great. Thank you, Steve. And on that note, I'm sure there are plenty of discussions still to be had. I'd invite all of you, if you could, to stay and join us for drinks in the alcove of the long room here.